So I'd like to thank all the speakers for their preparation and the reviews of the slides. And I'd like to open up for discussion. I know that Dr. Bornhart had a couple questions he'd like to launch with, and then we'll continue the discussions there.
Anytime I'm in the room with a smart guy, I always like to pick their brains. So, Dr. Byers, let me ask you a couple questions that I think I've often wondered about, and now that you're here, you may provide some insight. Could you go in a little bit more detail about the relationship, the tissue relationship or tissue basis of the association between bicuspid aortic valve and ascending aortic dilatation? Or is that no?
So there's a very fine distinction between a smart guy and a smart ass, but I won't bear on that too much. It was, you pointed out that it's possible to have, so when bicuspid valves were first recognized and really thought about, and the imaging was there, the explanation for aortic dilatation was assumed to be basically hemodynamic. And that is that you would get distorted flow, and so you would get involvement. If you look, you get a few different patterns of involvement. You get, in some cases, you get isolated root enlargement. In others, you get basically what looks like a sort of a broad enlargement along the way that is almost the same. So it'll be 4.5 centimeters from the root all the way up to the innominate on the right side. And in others, you get a normal root, a normal junction, and then you get ascending aortic aneurysms, these are the ones that are hard to see on the basis by looking at echoes. So the idea that there is hemodynamic involvement is certainly present, but now it's thought that most likely there's an underlying genetic disorder. I mean, there is that we haven't identified in many people. And so you have, for example, with Notch1 mutations, this is a signaling defect, and so signaling with various ligands that would interrupt that. Then probably introduce alterations in the matrix because these stimulate matrix proteins. And so the effect probably is one that's similar to the kinds of things that you see with mutations that are present with genes that involve the extracellular matrix, although they may involve other aspects of signaling. But I think that we don't know precisely what it is that's wrong. But I think that we've changed dramatically from the idea of a hemodynamic explanation to one that's a defect in the underlying substrate of the aorta.
One other question, if you don't mind. You know, when I've looked at these genetic reports, sometimes I feel like I'm looking at an FAA report, you know, Federal Aviation Association.
Don't fly here.
Yeah, don't fly here and all this. So is there any way, I mean, we know so much now about what you've just presented. It seems to me there should be a movement toward the report saying this patient may possibly have this aortic involvement or, you know, some stars with references or something. Any thoughts about sort of pushing the clinical recommendation envelope a little bit more?
Yes. It's a very interesting problem. It's a very difficult problem. So more and more, if the commercial laboratories depend almost entirely on algorithms to define what's abnormal, and their interest is in determining whether the alteration in any given gene is associated with clinical abnormalities, not what the clinical abnormalities are. You know, what's the likely clinical outcome. I think that those are, and so that's the large commercial laboratories. The ones that grew out of academic bases are much more likely to say, you know, in our experience, we've seen this kind of presentation with these sorts of mutations, and that this is what happens. So, for example, with Marfan syndrome with fibrillin mutations, you're much more likely to see dislocated lenses with people who have substitutions for cysteine residues in the protein, and that's because those cysteine residues hold the protein together. There are certain mutations that look like they ought to be full-blown Marfan syndrome, where there's a lot of skeletal involvement, there's a lot of ophthalmologic involvement, so dislocated lenses, but they don't have much in the way of aortic involvement. And they are aortic sizes are quite stable up through their, their 6th and 7th decades. So if you use laboratories that are used to those kinds of analyses, you'll get that. If you use the large commercial laboratories, you don't have a prayer. And even if you talk to the people there, you don't get it. So, and the thing that's missing is good natural history on the background of specific mutations. And the funding for large, good clinical databases is not very good. It's one of the things that, everybody thinks should be done, but isn't done effectively. So ClinVar is a large accumulation of mutations, but with very little clinical information involved in it. And then some of the groups, like us, like some of the French groups and others, have done a job in trying to collect the clinical information about patients so that you do get recommendations. So we had the experience here where there was a family where there was a woman who had a SMAD3 mutation in the family. She had not had children. All the women who had had children in the family had not had any problems with it, but she wanted her aorta replaced. So, we can go back and look and say, that's not, it probably isn't necessary with your aorta, even with your aortic root being 39 millimeters, just above the normal range for her. Whether that gets taken into account or not is something else that's very different. So,
We have some questions in the back. Dr. Hayes?
Excuse me, a question for Dr. Brokenborough. A patient presents, we'll talk about this later in my talk, but a patient presents to the ER with chest pain. And clearly, the three largest concerns are coronaries, PE, and do they have aortic pathology. Can you comment on the so-called triple threat CT scan, its expense? When should ER doctors do this? Because clearly, if everybody got one, it's going to overwhelm the system. But maybe, what are the pros and cons of the triple threat CT?
I've talked with ER physicians about this, and I think they like to, be able to differentiate clinically between a PE and aortic pathology or coronary. But a lot of times, so a lot of times we're look for aortic and PE, but not necessarily the coronaries. So I think it's a fantastic study. And we get, depending on the CT scanner, we can get a beautiful look at the coronaries. It's just not ordered that much, and I would have to defer to my ER colleagues as to why. But we have, and some of it's, there's more post-processing that goes along with coronary CTAs. So those are all post-processed with our 3D lab. And so that it's not a 24/7 service at this point. If we had the demand, we could probably create that, but we have to, have that demand. So I would defer to the ER people but I do think they like to differentiate, hone in a little bit more based on the clinical, based on the history.
I have a second question, Sam. This is for Dr. Byers. I'll give you an example of what we're seeing out in the battlefield, so to speak. I saw a relatively young woman. She was probably in her mid-40s. She had an isolated hypogastric artery aneurysm. Her brother had had an aortic dissection. So she is sent to me with the question, do I need to worry about this? Does my family need to worry about this? Do my children need to worry about this? I mean, where do we kind of draw the line on this?
So the pickup for genetic alterations is much larger. Did he have a type A dissection? Or?
Yes,
yeah.
he did.
So the chances of finding something is much higher in that group. With isolated abdominal aneurysms, the likelihood of finding something is small. So here you have to say, well, in the context of a familial aortic aneurysm, does a hypogastric artery alteration make a difference? Can it be part of the same syndrome? So the answer is yes. The best person to test in that context actually is the brother. And also a good family history to ask, most people have not had echoes and not had any kind of imaging, but you'd like to know if there's anybody that's died suddenly, had other vascular catastrophes. But the place to start in terms of testing probably is the brother, and if you find something, then you have a specific mutation that you can go back and look for in the sister.
And then what do you do with that information when you do find something? Say you have that index case, you screen them, you find one mutation, and you go to the family to find out what it is. How does that precipitate into what you envision as a family scan or a preventative module? Should they all get CTs, get echoes? Where do you go with that information?
So we would start, I mean, the thing that defines the risk is actually the presence of the genetic alteration. And so rather than screen, the advantage of having a genetic alteration is that you don't need to do all the other either invasive or non-invasive procedures. I mean, I guess everything is called non-invasive even if you inject something, but you're not cutting people open. But it means that you don't use expensive screening tests. You can use a specific test that says you either have this mutation that's in the family or you don't. If you don't, you're back at the background rate for being involved. So our procedure, and these things can be done from a distance. We can send saliva collection kits to people. They just drool in a tube, which is, you can get it anywhere from this size to that size. We can sample tissues from previous surgical interventions. If we have tissue on a slide, we can sequence that, looking for the one specific alteration. So we can do cascade testing in the family. That is, we test out in the family until we get an endpoint where there isn't somebody involved, and then their descendants are not at risk. And I think that that's the most efficient way to do it, and it really avoids the problem of doing a lot of fairly expensive assessments for people. If you don't find something, you're left in that same situation. Then you do go back and assess, and then you pick the modality which is most likely to find the things that you've identified. And in the case of having both, mutations or vascular abnormalities in different places, you may have to depend on having CT with contrast and able to see everything that you're looking for.
Very good, very good. Dr. Lair had a question, then Sean.
For Dr. Byers, with anything we do, there's always risk and benefit, and a question that patients often ask me if we're talking about genetic testing is, how does this affect my life insurance? You know the answer to that. So if you get a genetic screen and come back with these possible mutations beyond the clinical significance, how do we answer that patient question?
So the insurance is, there are different kinds of insurance, and they're affected differently by genetic stuff. There's a Genetic Information Non-Discrimination Act, which prohibits the use of genetic information in terms of the provision of health insurance. So it doesn't mean that you can't underwrite, which means you can't necessarily adjust the amount that people pay for it, but you cannot refuse it for health insurance. Life insurance and long-term care insurance are considered in a quite different basket, and they're considered more optional. Health insurance is not yet considered mandatory, but I'm sure at some point in the future it will be. They're considered optional, and so, already non-genetic testing, like even cholesterol testing or things like that, are used to adjust rates, and in some cases to deny insurance if there's been a prior event. Testing is not well recognized by life insurance companies or for long-term care in terms of what the implications are, and so often will be overlooked. But it may be something that makes a difference. So life insurance and long-term care are influenced by that, and one of the best things to do is to have life insurance, if you want it, in place prior to testing. Although, if they're coming to see you because they have an aneurysm, that's going to be part of what is assessed by the life insurance companies. And having a genetic test doesn't change that. It just gives a reason for it. But they will be much more familiar with the idea of having an aneurysm or a dissection than they will be a genetic alteration.
Thank you. Sean?
Dr. Brockenbrough, we're in the clinic, we're trying to set up there's a certain point, usually I saw the CAT scans are the 9s and the MRs are the 8s, and these people are getting, in some cases, lifetime follow-up. So is there thought about transitioning from CAT scans to MRs at a certain point in their follow-up so that to save them the radiation load? Is there like any thought about that?
I think
for
that,
chronic issues?
yeah, I think that's a great idea, especially in younger women. We don't want to, be radiating breast tissue for, years and years. So I think it's appropriate. I think, an initial baseline CT is good. I haven't seen written recommendations about this, and it's highly dependent on the MR quality. Here, it's very good. So I think, I think if you're following it, and you kind of make the switch to apples to oranges. I mean, there's a little bit of difference. It's a little bit tricky to compare a CT and an MRI by about 1 millimeter or 2. And it depends on the scan. But I think, I think if you've got a couple CTs as a baseline, and then you go, and you think things are relatively stable or not changing too much, I think an MRI is fantastic.
What do you think about switching to ultrasound imaging
For
any part of the arterial tree that you're looking at?
again, it's pretty tech dependent and lab dependent. I'm a CT person, so
It's like asking me about genetics, right?
The pictures are, beautiful. So
We respect your honesty.
I will say, just to chime in on that, just observations over the 30 years is that there continues to be a significant variability between ultrasound, and I think it is tech dependent, but quite often the ultrasound can either undercall or overcall, and sort of CT is still I think the gold standard for assessing ascending aorta. Would you agree with that, John?
Yeah, I think in bicuspid, if you're only having root involvement, aortic root only is involved, then it is reasonable, and the guidelines would support that to obtain echo follow-up. So you avoid cost, you avoid radiation, but otherwise, you really can't. Seeing the arch and the ascending is
The ascending is a
difficult
problem, right.
by ultrasound.
And I think it has a lot to do with getting an orthogonal view, so that you're not cutting it tangentially. Is my-
But once you get into the descending aorta or the iliacs or places like that, or the carotids, I mean, it's been used for a long time in terms of carotid assessment, you can get those kinds of views, but they're fuzzy images. I mean, they're much more fuzzy than CTs, but if you're not concerned about 1 or 2 millimeter enlargement, but you're concerned about 5 or 6 millimeter enlargement, is that enough? And is the technology good enough so that it can be standardized over a few years?
Well, again, I think that there's a high degree of variability in the course of the aorta, the ascending aorta. If we're talking specifically about that, what Dr. Amaro was referring to.
You just can't see
Right.
You
it.
can't see it.
Not the ascending aorta, but once you get beyond that,
Abdominal.
or descending down.
Descending, you can't see.
Same thing.
You can't see it at all.